Okay. I'll start by thank you, Louise, very much, and your team, Leah and Chantal, and everybody who has been involved in the organization of this terrific event, for inviting myself and Eva to come and present on our new initiative, Value-Based Healthcare Canada. And I will speak to that in a moment. How do you click these slides? Oh, here we go. It's a green arrow. So the center, we've heard, and we've heard many presentations now that spoke to both the challenges of improving health and health care in the Canadian population. We also heard about many great opportunities. The objectives of Value-Based Healthcare Canada was to create a hub that would allow for or reduce duplication of efforts and allow for a kind of a systematic way to link the opportunities that exist currently in Canada and to link the good evidence that already exists together so that we're building on each other's efforts as opposed to reinventing the wheel or duplicating efforts. But maybe I'll just a quick overview. I know Jennifer Clausen from BCG spoke to some of these statistics. But the bottom line is that healthcare expenditures in Canada are very high and, in fact, are among the highest expenditures compared to our peers, our international peers. It is estimated in 2018 that expenditures equal close to $7,000 per person, which represents about over 11% of Canada's total GDP. So the question is, that's wonderful. If it's $7,000, that's well spent, and patients are actually experiencing the value of that care, then one could say it's money well spent. But I think that's what's coming into question. And because Canada does not perform well, so while our healthcare expenditures are very high, our performance ratings are quite poor compared to our peer comparative countries. Some of the factors that contribute to the healthcare expenditures are availability of resources. We do have fewer human and capital medical resources than our peers. The use of resources, they are consumed at higher rates for some demands, while at lower rates for the rest. Access to resources is another contributor. Again, we're worse than average on timeliness of care and cost-related barriers to access. So what happens is patients or people's outcomes are worsening while they wait for the right diagnosis or treatment. And then the quality and clinical performance is good for some diseases and quite poor for others. So just provides you with a bit of an overview of what contributes to the high healthcare costs. So this can be, healthcare costs can be addressed in different ways. It's by, of course, by reducing waste in the healthcare system. And so the discussions we heard, and we're engaged in today, talked about it. They're all, the focus on being patient-centric and being able to provide patient-centric care. And, while we don't want to be focusing on cost, we saw the equation that value is equal to patient outcomes over cost. And so we can't really separate that out. So while, and we also can't boil the ocean in one day. So while we want to improve patient outcomes, we can't do that without also having some either reinvestment in the system or new resources come into the system. And so there are certainly opportunities to reduce waste and improving efficiencies in the healthcare system. And this can, of course, again, be brought back to by focusing on patient outcomes and what really matters to patients, and through systematic and standardized measurement of outcomes, allows us to examine more comprehensively how waste can be reduced. The full continuum of care needs to be addressed as well. As we heard, value-based health care is intended to address not only treatment in the hospital setting, but also getting to the patients who are at risk for diseases earlier on, or even healthy patients, to ensure, kind of putting health promotion efforts in place to ensure that people are not getting ill and don't become patients down the road. And finally, we can organize and deliver services around patient needs so that, again, we are appropriately addressing the needs and outcomes that are most meaningful to patients. Overall, one would say that by focusing on the patient, the different perspectives of various stakeholders and our activities will lead to kind of more positive outcomes. So all of this, of course, and everything that we talked about today requires a healthcare transformation. And while this is happening in smaller pockets, ideally we could scale some of the great examples and opportunities and identify and showcase some better practices that allow for sustained change to happen. And value-based healthcare affords or allows for this type of transformation, lends itself to that. To achieve the best outcomes for patients at the most reasonable cost. We heard from our colleague Akai that everything needs to be measured because we need the evidence to inform us of what outcomes matter to patients for one, but also which aspects of healthcare delivery actually produce better outcomes. And, maybe to kind of wrap this whole idea about healthcare transformation up is that currently large-scale implementation of value-based healthcare is certainly a challenge. And I've learned firsthand, while the concept is quite simple and everybody nods and it makes sense, it's very logical. Patient-centered care and deliver health care that matters to patients or to address patients' needs. However, there are so many political and vested interests and just data access, data availability that pose challenges to actually be able to implement the approach in a systematic manner. So we launched Value-Based Healthcare Canada, and again, as I mentioned at the beginning, we are first off starting out by looking at the good examples and opportunities that already exist in Canada so that we are building on top of what's already being done. Jennifer Clausen also mentioned that we have formal partnerships with international organizations, which allows us to, as Canadians, as kind of a coalition of our own here, to learn from international examples and have those conversations. So by having kind of a formal hub for VBHC in Canada, we can have these formal, not that we could otherwise as well, but it just allows for more systematic exchange of information between different jurisdictions. And again, we can build not only on our own good examples and efforts, but also those of our other jurisdictions. We had a call just yesterday with somebody in France, and that's sort of leaving. It wasn't somebody from VBHC France, but a colleague of theirs, and we're talking about representing VBHC Canada at an international meeting. And interestingly, while we here feel that our kind of partners or colleagues in Europe are more advanced with VBHC, the comment that came from them directly, we'd be so delighted to hear about what Canada's doing because you guys are so much more advanced than we are. So it's interesting to hear that. So I'll give you a quick overview of a description of what our goals are and what our activities are at Value-Based Healthcare Canada. We have a strategic research agenda, and we have a strategic capacity. We call it a convening program, but it's more a capacity development agenda, because what's needed now is to build those strong and formalized partnerships between all the organizations that are here, as well as with others that are not even at the table. And within Ontario and Quebec, but also with all the other provinces. So again, just to facilitate the learning and scale good examples of VBHC efforts. So we're doing this through policy research. We're documenting the good work that's already being done through policy research. We are in the midst of completing kind of a policy primer that synthesizes all the good work that's been done to date, building on some of the other some of the existing evidence. We also examined provincial mandate letters to see how ministries' priorities align with VBHC kind of criteria or principles. We developed a repository for value-based healthcare initiatives, and we did an environmental scan and identified initiatives across the country, and so we pre-populated this repository with these initiatives, but the intent is once launched, and we're probably going to be publicly launching this repository and sharing the link to it publicly on November 22nd, which is our next strategic meeting of our partners. But in this, it's intended to be an active way to raise awareness around a standard way of even talking about VBHC. You know, people define value in different ways, and kind of have a different sense of how value-based healthcare can be measured and promoted and scaled, et cetera. So look for that. I think it'll be a good way to also allow people to incorporate their own initiatives. So if you don't see your initiative listed there, but you've just launched a new project that you believe aligns with value-based healthcare, even if you're not leading it that, calling it that, then you can certainly, you would send us the information, we would add it to the repository, and we also use an assessment tool that sets out the criteria of VBHC based on the definition put forth by Porter and Tisberg to not to evaluate, but rather to provide a sense of how an initiative that that believes that calls itself a value-based healthcare initiative, how closely aligned it is with the formal criteria or principles. So again, it's intended to be a learning tool. And then finally, and Eva will speak to these, we are launching demonstration projects in a number of areas. And this has probably been our kind of most exciting effort to date because what we found initially, we looked for opportunities to launch smaller projects, identify clinical sites, and then through conversations with our partners across sectors, we learned that the more efficient way to go about this is to identify opportunities and projects that already exist, or organizations that are already forward-thinking and are innovative and are already applying some value-based healthcare principles. And so what we will do is with our demonstration projects is we will provide a methodological structure that is, or like a framework, if you will, an evaluation framework almost, that will be a standard framework that can be applied to these projects so we can systematically and in a standardized way measure outcomes. And then, because it's a standardized approach, we can then scale the findings to other jurisdictions. Part of this will be like the first phase. I'll let Eva get into the different phases, but validation of PREMs and PROMs in the Canadian context, for example, is kind of the first phase of this work. The areas that we are currently exploring are cancer, diabetes, and cardiac care. And we've identified, again, some like in diabetes, for instance. So Jennifer Clausen mentioned the project, the World Economic Forum project that was launched together with BCG, and there's one, it's a heart failure project in Atlanta. Well, there was a sister project launched in Ontario just I guess less than, I think it was January or February of this year. And because of changes in government, the project very quickly was put on hold. And but the methodology was developed. The stakeholders, the partners that worked on it are very interested in seeing how we can reactivate this project. So we are now looking at how we can do that and use that as a demonstration project. So there's just some examples, and Eva will speak to the rest. And these are our, so as I mentioned, we are a consortium, a coalition, and the Conference Board of Canada is a not-for-profit organization. All our work and efforts, activities, projects, convening activities are only made possible through membership fees that are contributions of partner organizations. And the case of Value-Based Healthcare Canada, it's the same thing. We have partnered with, they're not all listed here, but with some key organizations that have a motivated interest to see positive transformation of the healthcare system and have invested in this initiative. And so we're working together to develop that plan. Thank you.
So I'm from the Quebec Cancer Coalition, or la Coalition Priorité Cancer Québec, and our mission is actually to improve the healthcare system in oncology in Quebec, but we love to participate in these events where we get to learn best practices from across Canada, and really it gives us an opportunity to share with people outside of our comfort zone in oncology. I actually really appreciate these kinds of meetings where we can learn from other patient groups and other voices that we usually don't get exposed to. So I really appreciate that. And now I will be able to use my slides. I'm very excited. So it's all Louise Binder's fault, as usual. Usually stories start like that. And because we started hearing about value-based healthcare, and also she's an expert dot connector, this is how I was introduced to Monika and the Value-Based Healthcare Canada. And in talking, we realized that actually, Quebec wasn't even on the radar at first, I think, but that's normal. We're usually in our corner doing our own special thing. I know. We have that reputation. But it turns out that in Quebec currently, we actually have a really ideal environment for value-based care. And there's a couple of reasons for that, and I'd like to talk about them. Number one, as you know, because they do some controversial things that I won't comment on, and we're not here to talk about those things. We're only here to talk about healthcare. But for healthcare, it's actually a fantastic government, okay? And the reason is, they're not the usual, we always had two parties, like almost everywhere. And for now, this is a brand new party. It's a third party, and they're open to doing things differently. They're a lot more humble in their approach. They don't assume that they have all the answers, and they genuinely do consult patient groups a lot more and other stakeholders. So that in itself is really good. The second thing is that it's a majority government, so they can actually get things done. And they are getting things done fairly quickly, some good, some bad. But in healthcare, again, we're in general quite pleased. The other thing is that I know that a pilot project is almost a bad word in some provinces because they just kind of say pilot projects. But in Quebec, we do almost everything in a pilot project. Everything starts with a pilot project. However, I have to say that we're fairly good at, once we've done these pilot projects, we're not so bad at actually making them spread. Sometimes it's really, really slow. But one really interesting innovation of the Quebec healthcare system is that a couple of years ago, there was a joint decision and mandate from the Ministry of the Economy and Innovation and the Ministry of Health to have something called the Bureau of Innovation. And so there's one main person in charge with a very tiny team, but his role, Paul Larchevêque, who's the chief of this Bureau of Innovation, his role is to actually take really good innovations in the healthcare system, code word pilot projects, and to convert that into something actually widely scalable and implementable. And the fact that there's actually someone whose mission that is really promising. What makes it more promising is that this person in particular is very forward-thinking and loves value-based healthcare. So that's already a big plus. So we have a couple of allies within the government. Further, the actual Ministry of Health, the minister for the first time in 3 or 4 mandates, is not a doctor. And she's also a woman. Not that, it kind of has something to do with it. She's also a social worker, which means that she really, really does. And I mean, she could have been a terrible social worker, but luckily she's not. Like, just because she's a social worker doesn't mean she's amazing. But in this case, she really does have a very humanist approach, which is great because it really does fit really well with the value-based healthcare approach of putting the patient in the center. She genuinely believes that the patient should be in the center, but also that there's more than just the doctor that should be included, and more than just the regular clinical outcomes that we always look at. So that's also very promising. Then there's Ines. We saw Ines this morning, and I'm sure that you've heard kind of little birdies buzzing around that, they're doing things a little differently. We got to see a little bit of how they do it. We were really excited this summer when they came up with their strategic plan, and they were like name-dropping value-based healthcare all throughout their strategic plan. We were like very happy about that. And we know that they have an approach that's much more based on getting away from pure cost considerations and really looking more at the big picture, on the impact on society, but really trying to listen more to patients, and we do plan on working closely with them to make sure that we can even improve that further. But their openness is already very refreshing. And then finally, I did talk to you about the Minister of Health a little bit. Just last week, the minister made a decree where they're going to have an experimental project to last for 2 years to do something that we should have done a long time ago. And when I speak to patients that aren't super aware of what's happening in the healthcare system, they always wonder, why wasn't this done before? We're going to start measuring costs. We currently don't know in Quebec, and I'm pretty sure that it's the case in the rest of Canada, we don't know how much Eva Villalba costs when she goes into the healthcare system, goes through her whole journey, and then gets released from the hospital. We don't know how much she costs. We have no idea. It's like a magic black box of a number. And so the experimental project is actually to count all of the expenses. In the US, they know because patients are actually revenue and not costs. But here we have no idea how much a patient costs, how much it costs to give the wrong medication versus, are we lowering hospitalization? So it's a really interesting project that aims to find all of the costs throughout the care trajectory. So all of these things make Quebec a really good place to start looking at value-based healthcare. So what we decided to do with the Value-Based Healthcare Canada initiative is we looked at how can we do it. Of course, we're in oncology, so that's where our contacts are. But we also have exposure to these amazing clinicians and researchers that are also really interested in proving that putting the patient at the center and really listening to patients and doing what matters to them is not just good for the patient, but it's also good for the system. And so we really identified the opportunities to work with these very forward-thinking leaders because it's a culture change. We did talk about culture this morning. Culture is important, and all changes at the system-wide level, they usually come to a big obstacle, a big barrier when it comes to the shift in culture. So in order to do this demonstration project, we needed to identify leaders that could mobilize their teams internally and that wouldn't have this resistance to culture change, that could have people on board to be, yes, we want the patients involved, yes, we want to validate what matters to them, we want to measure everything. That's not necessarily the case everywhere at once. So we wanted to pick centers based on that. Then we wanted to look at what actually exists in terms of validated standard sets. And we did talk this morning about the ICHOM standard data sets. In cancer, there's 4 that currently exist. And so we're doing 3 out of 4. And it's also because we have good standing relationships with the patient associations that are related to these. And so we're going to ensure to work very closely with them and with the patient populations to ensure that we're always on track and validating what patients really want. So the 3 patient segments that we are going to look at is breast cancer, lung cancer, and colorectal cancer. So we're going to start off by, we've already identified, I put it briefly, we've already identified 2 centers in Montreal and 2 centers in Quebec City. And the reason is we do want to represent a little bit more that regional difference, even though we aren't going to the the true, what we call les régions, like the more rural areas. And the reason is because we are looking at the centers of excellence. So we're starting with the best practices because the whole point is for this demonstration project to serve as the data and the information, the tools that the government will need to end up applying this at a more systematic level. And so that's why we do want to aim high and have very high standards. We still do want to identify where there could be issues in applying it, province-wide, but that'll be at a later step. So one of the first things that we'll be doing in this demonstration project is to take those standard outcome sets and to validate them with the patient segments that we're going to be studying. So we're going to be much more specific than just breast cancer. We'll be talking more, let's say, about metastatic breast cancer or young adult breast cancer. And so really validating those outcomes and making sure that maybe we won't do all of them at once, but which ones should we be prioritizing. Then we also want to optimize the care trajectory. So this is one that was done by the Quebec Lung Association, l'Association Pulmonaire du Québec. And so we just want to validate, are there bottlenecks? Are there delays? What are the costs in the trajectory? Are there things that we're missing? Now that we know what healthcare outcomes we really should be looking for, does that change the way we've been treating people? And so the lung cancer trajectory it's kind of fresh, but we don't even have it for all cancer types. So it's really an opportunity to kind of expand those best practices. And then, of course, we will measure outcomes, costs, delays, and very importantly, we have gotten the approval in principle of different levels of the government, and the idea is to keep them very, very close in the loop and to align this project with their priorities in order to make sure that the data that comes out of it is actually something that can help them to apply this in the real world. So it'll have much more of an impact if we do it this way, rather than doing what we always accused government of doing, which is not collaborating with stakeholders. So this is putting our money where our mouth is. And this is, very briefly, it's basically going to go through 4 phases, and it'll take about 2 years. So it's realistic, it's feasible, it is quite ambitious, but with the collaborations that we have with Value-Based Healthcare Canada, and we're also having lots of partnerships, like I said, with patient associations and with the doctors themselves. We're really getting close to the doctors, aligning ourselves with the government. We really do think that it's very feasible. So finally, I will end on this. Number one, if this is happening today, I would blame the DPPS or what the newly branded this annual meeting. And the reason is because this idea was just a seed planted last year when I came here in the same room, and it just really motivated me to apply value-based healthcare, which allowed me to see the opportunity when Value-Based Healthcare Canada actually was created. And so my call to action to you is, what are you taking away from this meeting? What can you bring back to your territories and areas and fields of expertise to really apply it in real life? Some of you might have wondered, is it worth me going to Toronto? Plus it's snowing now. Well, I'm here to tell you, yes, try to meet with people that you otherwise wouldn't speak to, and try to find opportunities that you otherwise wouldn't necessarily think of. But also it's very empowering to see that patient groups can actually make a direct impact on our healthcare system. We just have to work in collaboration with, maybe not always the same stakeholders, maybe others that you wouldn't have thought of. And this is a great opportunity to kind of reflect on that. And to step out of your comfort zone and to speak to other people and maybe to see what else can be done. And so I leave you with this. What change do you want to make happen, and who can you work with to accomplish your goals? I'm sure these people are in this room today, so you can start thinking about it. Thank you very much.
Thank you. I'd like to ask the panelists, with regards to value-based healthcare, is the system able to take into consideration those atypical patients that need a more costly type of treatment? So for instance, in the world of oncology, I'm talking about something like CAR T-cell therapy. I mean, we all know the cost of that treatment, very expensive. And especially with the Quebec system, I know they've approved and it's now accessible to patients in Quebec. So I'm just trying to figure, can you take that patient into consideration as part of your value-based healthcare assessment, or is that individual an outlier?
So, is this on? Yes? So that kind of patient wouldn't be included in our demonstration project, but it absolutely would come into consideration once value-based healthcare would be applied at the system level. And the reason is because that patient, you would be able to compare the cost of giving that person CAR-T and that person reintegrating society compared to either that person being a huge burden on the system or dying, which is even worse. So that comparison, we don't even know how much a patient costs currently. So we don't know that CAR-T is actually saving us money. But yes, we did approve $35 million budget for CAR-Ts. Yay for us, like we're excited about it. But it's kind of just, let's see how it goes and we'll kind of measure along the way. Until we have those measurements though, we can't make those decisions. But once we do have the will to make those measurements, to measure those things, and then to do the comparison, to say it's absolutely worth spending $400,000 on this person, because if they had a chronic condition or if they were ill or they had remission, they had a relapse like 3-4 times, it would cost us way more than $400,000. But currently we don't have that data. But in a value-based healthcare model, that would be the consideration.
Thanks a lot for the great presentation. My question is related. I think it just makes total sense that the first areas of focus are basically we're looking at in the oncology space, at least, you know, the deadliest and most prevalent types of cancers. But I was wondering, do you see any value okay, maybe I shouldn't use the word value, so not to use value twice in a sentence, but the benefit of implementing a value-based healthcare in Canadian healthcare system in future in terms of other disease areas, for example, genetic diseases, and do you see any opportunity for healthcare system to move forward from kind of more traditional therapies, let's say small molecules, to more, I know that they're coming in, but still Canada is not really doing that great compared to other countries, especially Europe, for instance, to, I don't know, more like gene therapy, gene and cell-based therapies, or oligotherapies, for example, that are becoming a really hot topic these days. Do you think that value-based, basically, healthcare can kind of tackle those issues? Thank you so much.
Thanks, Ines.
So maybe I'll address that by just saying that the intent here with this initiative and with the partnerships that we're creating is to inform policy. And with the demonstration project, so yes, right now we're not addressing every sort of variation of a cancer patient, for instance, or different drug therapies that are available and accessible. But what we're doing is identifying data that are available and or data collection mechanisms that are required to be able to produce evidence that we can then use to go to, scale the findings to a system level and inform policy change. So so in order for, like, we all want to see policy change, and we would love for systems to adopt value-based healthcare as a kind of a platform for moving forward, for informing procurement and for reimbursement models, etc. But the model has to be tested, and as you know, with all policy, the evidence needs to exist that we can, so we can justify the changes. And so what the demonstration project is serving to do is to create evidence in this context. There
is, however, an element that we will address in looking at, especially lung cancer, but it's even applicable to breast and colorectal, which is the importance of proper diagnostic screening. Because you're talking about personalized medicine and rare diseases. Personalized medicine is basically going to have to be treated like rare diseases in the sense of evaluation and in the sense of small population and even the lack of data, right? And so the idea is that with proving that value-based healthcare, or for example, screening people adequately for biomarkers in lung cancer, will actually allow us to give them the right treatment at the right time and save the system money, but also dramatically improve outcomes for patients. And so it's a win-win situation, but the demonstration needs to be done, and that's what Monika is talking about. But that element that you're talking about of the importance of diagnostic screening and precision medicine, it totally makes sense in a value-based healthcare system, and that is why we're trying to do this now so that we can be ready as a system, and maybe Quebec could be first and then quickly spread the contagion, the positive contagion to the rest of Canada, so that we're ready for precision medicine, because our system is not ready. It really needs to adapt to this new reality.
And maybe just one thing that I'll add, so you asked about other clinical conditions. So we are launching projects in different areas to tackle or to create evidence, to produce evidence for different components of value-based healthcare. And to give you an example, in Ontario, just recently there was a reimbursement. The ministry is supportive of a new reimbursement model for patients with aortic stenosis, and so now we're collaborating with Core Health and other partners to see how we can evaluate. So in this case, it wouldn't be, yes, we would still be validating patient-reported outcomes for that specific patient population. We would still be measuring or looking for data that's available to measure outcomes and costs, but also we'll be doing an evaluation of different interventions that are currently accessible to the system and then the resulting costs. So it will inform the reimbursement model side of things. So we are launching then in diabetes care or chronic disease management. We are going to be looking at sort of the preventive community and primary, how value-based healthcare can be implemented in the primary care setting, for instance. So we are sort of, selecting areas where we can launch demonstration projects to build the case for value-based healthcare as a whole.
Okay, and we have a number of other questions. Hi, thank you both so much for your presentations. And I think one of the challenges that we see around value-based healthcare is the common problem of piloting over and over and over again and not being able to move things to scale. And you had talked a little bit about the environment in Quebec, and I'm just curious for some comments on what role you see for the Innovation Bureau in taking these pilots and making them scalable in an environment where we still want to allow choice. So I'm just curious what you see for that.
So I think one of the most important things is to make sure that the projects, whenever there's demonstration projects that will be happening in the rest of Canada, that they really do align with what the Ministry of Health is looking to do. Not just what they're doing currently, but some of them are actually more forward-thinking than we think, and you wouldn't know unless you ask them. And so it's important to know, what would help them apply this at the system level. And so in terms of converting it to kind of more in the whole system, I think that working in alignment with what their objectives are really helps to facilitate that. It prevents some of those obstacles. This is nice data, but actually it's not going to help us because we're going off in another direction. And to really just validate what data they do need in order to apply that. And then kind of doing some of that education. But in our case, we really do believe that our representatives that we're speaking with at the government level do understand the value and the applicability of value-based healthcare even beyond the demonstration projects that we're having. But we've committed to really keeping them continuously engaged throughout the process. So if it's going to be 2 years, I've already had one meeting with them. I'm already planning another one by the end of December. So it's just keeping them in the loop will really help us to even do that education of how can this be applied elsewhere, even though we're not doing it currently, and making sure that the data is actually useful to them.
So I think Leah's got a list, so if you just get on the list. I think what we have to remember is that value-based healthcare is about a completely new way of doing healthcare business. It's not about one disease or a rare population. It's not about one drug. It's about, and Jennifer Clausen said it, it's not even about patients. It's about populations. So it's about determining what outcomes do patients in a particular population value. That's the only value that actually matters, in my humble opinion, not so humble, opinion. And how much does it cost? So to create that bundle of services, which may include a treatment, but may not include any treatments at all in particular cases. If it's a population that's young and healthy, it may be all about prevention. Who knows? But the key is we're going to turn healthcare on its head. It's actually a revolution in the way we do healthcare. So it's going to mean that instead of populations trying to wedge themselves into the pie chart of the drug budget, 6% for drugs, so I hope I can wedge myself into that 6% or 12% for hospitals, whatever it is. I hope I can get into that emergency room. It's the opposite. The pie chart are the populations and what it costs to look after that population in a bundle of services. And then those services go to the people instead of the people trying to fit into the services. Imagine that it's actually going to be a system that's about what the patients and the populations need instead of what works for the systems. So I think it works everywhere. I think it's revolutionary, and I'm really excited, Eva, that you are so passionate about this. That you're going to be one of the first places to try it, and that of all places, the Conference Board of Canada is actually willing to lead a revolution. No. Thank you so much.
I would make 2 points to that. One is that it is really a revolution. Currently, our system is not a healthcare system, it's an illness system. We treat people based on their illness and not based on creating health. And so value-based healthcare is really creating a real healthcare system where the person's health and all aspects of that health. That means not putting things in silos, not separating physical health from mental health, treating all aspects of the person and not just one aspect, not just the drugs, for example. So that's one thing, and I forgot the other thing. It'll come back. Go ahead.
No, I was actually going to piggyback on there, and you answered that very well for me, Louise, because I was going to ask. So, and it's hard for even us here because we have patients who have illnesses, and it is such a new paradigm that we still think of outcomes as clinical outcomes and being only that. So getting will you be charting patient time to appointments, wait times, indirect values, how the information was given, and have you figured that out? And maybe you can speak to those indirect value points that you're going to measure.
So we haven't, I won't claim that we figured it all out, because I think these measures will vary from project to project, depending on what we're trying to achieve with the project. But absolutely, so in the case, the cardiovascular, the aortic stenosis example that I gave, there it is all about wait time. So currently there are 2 procedures available. One's trans-aortic valve implantation. The other one is a more intensive surgery. And currently the wait time in Ontario for these procedures is so long that patients are dying while they're on the waiting list, or the complications are becoming so severe that then the health system costs just continue to rise. So absolutely, so in that case, wait time is absolutely going to be an outcome that we'll be measuring. So I think it'll depend on the population that will be, and the idea is to bring all these results and findings together to support the business model, if you was, yes, yeah.
And what I really appreciate about the conference board is that they're having a very multi-stakeholder approach, and so even the model that we're working on, the framework, is constantly adaptable to the different centers that we're working with to be really truly representative of those patient segments. And so it does have to adapt. And someone before asked, like, how will you adapt it to individuals that are more rare diseases? It's not like a one-size-fits-all approach. Once you understand the concept, it's really just about making it about the patient all the time, and each patient is their own rare patient, right? Like, everyone is unique. But once you have a framework, it's much easier to make those decisions. And once you just think, what matters to this patient? What matters to this patient? What matters to this patient? So let's optimize the trajectory to make sure that we can optimize those outcomes. Then you just apply that to everyone. But the outcomes will be different depending on each patient.
So just to add on to where Louise was going, you know that I am a staunch early adapter of value-based healthcare. And when we said earlier this morning, like, why don't we just like blow up the healthcare system and just restart over? And the funny thing is the catalyst to do that is value-based healthcare. Because if you project out what we would see happening is that people like Caddis and PMPRB, watch out, your job is on the line, because this data and all of this information is really going to push the decision-making and drive it better so that we can break down, get quicker access to innovative medicines and treatments and therapies and what have you, because the evidence will be so abundantly clear within a value-based healthcare system that you could not ignore it. It will be, all these questions, it's interesting, like CAR-T in Quebec. We don't really know what the cost is to not do CAR-T.
Exactly.
I come from a blood cancer world where prior to my miracle drug, we didn't know what it cost to keep a CML patient alive. And really soon I'm going to be celebrating 19 years of living because of it. And the cost has been, the government has saved tons of money with me because I can
pay a lot of taxes.
and I can pay taxes, I can work, I can raise a family, I can do also, I can spend money, I can be very contributing. And resources were not having to be put into the health and welfare of my child, who would have been very young had I not had the good outcome that I had. That creates, some trauma later on in life. It does affect her. It will affect her health outcomes as well. And that's something we never really take into consider, but we will see more of that when we go down the road to value-based healthcare.
Yeah.
So I'm sold.
I remember what I wanted to say following Louise's comment. It was about financing. And so the pilot project that I mentioned that the minister has announced, effective now and for the next 2 years, is actually to help us get to a reform of the way that we finance our healthcare system. So currently I think it's ridiculous. It's based on a historical budget for hospitals, and it doesn't reflect reality at all. And so they're already open to, within 2 to 3 years, going to a financing that follows the patient. That's already an improvement. And I can confirm that they're actually open to what value-based healthcare encourages, which is bundled payments based on bundled services that are identified according to the ideal trajectory, which take into consideration all outcomes, not just clinical outcomes. Rehab, mental health, survivorship, all kinds of other outcomes that are currently not included, and all of that would be in a bundled payment depending on the patient segment. And that is radically revolutionary, but there is an openness, and that's already good because there's not always that openness.
So, Eva, just one last thing. That sounds a little bit like pharmacare. It does fit in. It does fit in. It's maybe not the impossible dream, Louise.
That's another can of worms, and we're not getting into that.
Eva, I just had a question. Assuming your value-based healthcare projects, you need patient-reported outcomes, patient data. Do those individuals, the residents of Quebec, do they have access to that data, those PROMs and PREMs, indefinitely?
That's a good question.
Well, it's a very good question, but again, the demonstration projects are actually going to get at all these questions. So, will they have,
The answer is there's no current, it's not like they're currently being systematically collected. And so we basically need to develop a consensus amongst the 4 centers, how we're going to collect them, and what is going to be done with that data in terms of sharing that data with the patients themselves. But
and also considering what they're currently collecting.
Yeah.
So in the ideal world, and the reason we selected these centers of excellence is because they already have mechanisms in place that are likely gathering data similar to what we'll need to be collecting. So there'll be less burden on the clinical setting to collect new metrics. but so it'll depend whether that data they're collecting is maybe part of another research project, and then what kind of the ethics surrounding that are. So these are nuances that will need to be worked out, and it really will be specific to each demonstration projects and the clinical sites that are involved. But these are all, very important, relevant questions, and truthfully, also the barrier, the potential barriers that we need to sort of just navigate through. That again, when by linking ourselves to existing projects and initiatives, and working with sites that are open-minded about collecting new data and helping to sort of navigate through the various ethics processes, etc., will facilitate. And then as we, we're not optimistic, we're quite confident that as we have data in hand and are able to demonstrate the value of these approaches to better outcomes and healthcare system savings, then more clinical sites and governments will be open to such new data collection. So I know that didn't exactly answer your question, but but honestly, right now it's difficult to say who owns the data, because it depends on what data the sites are currently collecting, and who owns that data, and then whatever new data we will collect moving forward.
So I think when it comes to ownership, in principle, I think everybody could agree that we own our own data, right? And I think one thing with value-based healthcare, I think the flaw is we have a provincial system, but as residents of Canada, we cross Canada. Like, we live in different provinces. And so how do you do longitudinal valuation if the data is aligned to the province, but the people aren't? Just food for thought.
Yeah.
Fantastic questions and comments and dialogue. And so I know we are over time again, but I did not want to cut that short. This is, sort of the meat of the matter that we're getting to this afternoon. So we are due to go to a break right now. We should already be starting our next session with Stacey. Yes.